Yep.
So thank you very much, Hannah. And let's get started with the cases. Again, we've been lucky and we got like one very exciting and very interesting case. Having said that, that doesn't mean that we are going to know exactly what's happening, but I think we can together try to figure out at least or see if we agree on something. And then once we finish with that one, this is a case that came over the weekend. And then I got a similar case, but slightly different, doing my rotation over the weekend in teleradiology. So they are very nice to present together. So let's go first through this one. And maybe what I should do is what I usually try to do, which is share the link just in case through the chat. So let me come back. So you can already take a look at that case. I'll give you the history in 1 minute. And this should be the case number 16 for those of you that are in the forum. Okay, so that should be the link on the chat. And yes, these two are the images. The history is, this is a 1-year-old cat that has like sudden dyspnea after missing for 1 day. No obvious wounds and normothermic. So that's the presentation.
It actually presented 24 hours after starting clinical signs.
Cool. So take a minute, as usual, you can open the images through the link. You can also look at my screen. And then the exercise is always the same. And probably this one is going to be one where we are going to, so this is one of those cases where deciding the first question is if this is normal or abnormal is going to be very easy. It's clearly abnormal. And then I think we're going to come up with a long list of abnormal things. And then I guess the challenge is going to be trying to put them all together, you know, how we can make a story, you know, that explains all of the findings. So take a look, and whenever you're ready, we do the same thing as usual. You start letting me know what you think in terms of findings. Not trying to explain yet. I don't think it's going to be easy to explain what's happening, but just to, you know, start bringing the abnormalities. What do you think is abnormal? Many things. So come on. Actually, almost everything looks abnormal in that radiograph.
So, all right, I'll start.
Thank you for that.
Yeah, diaphragm looks intact there, but I'm having trouble seeing it on this one.
Okay.
And the stomach shadow might be tilted a little bit, so I wonder about loss of liver there. Could it be herniated through?
Okay.
There seems to be, can you see my mouse pointer?
No.
Okay.
I think you need to go back to the tools.
Yeah, I went on to mouse and it doesn't seem to be.
No, I think I'm the only one that have that power because it's my screen.
We'll try this.
You should annotate it.
Okay, so where were we? Sort of an air bronchogram type appearance there, but it's the wrong shape.
Okay, good. So can you show us and go back to where is that you see that abnormal diaphragm or basically you see that you cannot see the contour of the diaphragm, which we should be able to see. So if we don't see it, it's a good point. But can you show us exactly what you mean?
Well, I'd expect to see it somewhere around here,
Okay,
but
cool. And
it's
it's kind
not.
of hard to see.
It might just be border effacement. There's also where are we? There's also a where are we?
I like what that arrow is pointing
There's
out.
also something there,
Yeah.
possibly soft tissue density.
Okay.
There are circumscribed gas patterns here and
Okay.
here. Well, there's a number of them there.
Okay. So
Someone else
let's
can have a
find
turn now.
this. You call it like soft tissue structure, and it's gonna be in the right caudal abdomen, thorax. And then there are the other ones. Let me add that there are let's say rounded, round, gas opaque, well-defined gas opacities. Okay.
There's also air bronchograms there.
Okay. Okay. We come back to the air bronchograms. Okay.
A subcutaneous emphysema,
Very
and
good.
I think a pneumothorax on the right-hand side and pneumomediastinum, and possibly some gas in the retroperitoneum, but you can't really see it on that lateral.
Very good. So, Helen, do you have the power or the technical ability today to show us or to write on the images, or are you on the phone?
No, I don't, sorry.
So I'll do that for you.
Thank you.
No worries. Thank you for bringing those comments. So the sub-Q emphysema,
Oh, yeah.
I'll pick that up, you know, so they're probably here. Then, so that's easy. So I'm gonna take that one, the subcutaneous emphysema. I will be very interested in someone that agrees with the comment of the pneumothorax to show any feature of pneumothorax. Makes sense? So can any of you that agrees with the idea of pneumothorax point to the feature, the radiographic feature that is consistent with pneumothorax? What is? Yeah.
Yeah, we thought it was a pneumothorax. I'll draw. I don't.
Based on what? That is my. I personally I agree that there is pneumothorax, but I'm interested in going slowly and pointing out at the things that are triggering our thinking. So then we share that. Yes, exactly.
And then,
exactly. So,
sorry, the annotate bar was right over the. Hold on, I'll see if I can move the annotate bar. I'm finding it hard on the. So like here as well, and then there's also this little area down here.
very good, very good. I would agree with all of those. And probably we can make even that. So the overall idea is, we go back to the principles of pleural disease. So basically, anytime there is something in the pleural space, either fluid or gas, then radiographically, what we are after is that separation of the lung from the wall. So that contour is that separation. The lung should, this is the border of the lung, and it should be against the wall. Now there is a gap. And that we call separation of the lung from the wall. Same thing here, makes sense? So that is separated. And same thing here. So perfectly fine, I agree with that. That's extremely relevant, I think, in this case. Yes, excellent. So we have pneumothorax. And then there was a mention of pneumomediastinum. So there I'm also interested in you, let's say go back and tell us about for anyone, bring the features, you know, based on what, I personally, again, I agree. there is pneumomediastinum, but I'm interested in knowing based on what image, based on what line are you concluding that?
I thought you could just see the ventral border of the trachea too clearly on the lateral.
Perfect. So, and this probably should trigger people going back to seeing a normal radiograph. So in a normal radiograph, we see the trachea very easily because there is gas inside, and then we have the soft tissue wall. However, the outer border of the trachea is something that we usually don't see that clear. Makes sense? Because it's immediately against other tissues with a similar opacity. So we have the silhouetting as usual, like grapes surrounded by water. Now, if we put gas within that mediastinum, then we start to see things that sit normally in the mediastinum that we are usually unable to identify. One of them is the outer contour of the trachea. Most of the time, in addition to that, we see the root of the aorta, the brachiocephalic arch, the longi colli muscle, which is that thing, that border, and then we usually also see the esophagus. In this case, we don't see many of those, but we can clearly see the outer contour of the trachea, and that is consistent with pneumomediastinum. So good, very good point. So now we have many findings. Is there anything else that you want to point out?
There's some pleural effusion as well.
And that based on what?
Just because you can't see the border of the heart very clearly. What else did we see? And you can kind of see some, maybe a bit of fissure lines on the left-hand side.
Yeah, I agree. So probably there, make sure you don't confuse them with these, which are the cartilages. And when there is pneumothorax plus pleural effusion, then the features, the pure features of pleural effusion, which is that superficial lines, and then accumulation of that soft tissue opacity outside the lung, is not that clear, because now we are going to be moving the animal for the different positions, and now fluid is always going to go on the dependent side, gas is going to go on the top. So we may miss those pleural lines. Makes sense? Because if the separation of the lung, if there is gas instead of fluid in between those lungs, then we won't be able to see the classic appearance. So I like your first comment, which is and that goes again together with one of the first comments, which was the inability to see the contour of the diaphragm and the heart. So that, I think, is supporting the idea of silhouetting. Why is it silhouetting? Well, it could be because there is lung disease. Makes sense. If there is like severe lung disease, the lung is very soft tissue, fluid filled, goes against a soft tissue structure, then you have silhouetting or pleural effusion. So I think in this case there is a mild amount. It's hard to quantify when there is pneumothorax, but I think there is pleural effusion as well. Okay. Anything else? Or yeah. So summary up to now, we have subcutaneous emphysema, we have pneumomediastinum, we have pneumothorax, pleural effusion. Anything else? And then the things in the lung, which are, or I just said that they're in the lung. There are these gas, perfectly rounded, well-defined gas opacities. There's one there, there's at least one there and one there.
To me, the lungs themselves, particularly ventrally, look kind of whiter than you'd expect, sort of mottled whiteness, but it's hard when they've got a pneumo how much is collapse. So I don't know the relevance or not.
I completely agree with that statement, like fully agree. So the lung looks more white. If you go, let me pick like probably this part. So the lung looks a little bit more white than we expect, but your immediate consideration is also very welcome, which is, well, if there is pleural disease, there's going to be unexpected, at least some degree of atelectasis. If there is some degree of atelectasis, we expect that lung to be more radiopaque or less radiolucent because it's losing some gas. So trying to decide there if the changes are only due to the pleural disease and therefore atelectasis, or there is an underlying primary lung disease is also very hard. And I share that. I would not know that for sure. But it's excellent point.
And the thing that confused me a bit, I thought I could see this kind of like triangular opacity between the 6th and 7th rib, sort of dorsally. That to start with, I was thinking, is that something in the esophagus? I didn't know what that thing was.
Yes.
But that thing,
so Helen
yeah.
is referring to this thing. So I'm going to offer my explanation. That doesn't mean that I'm correct. So it's the opacity, I think, is more like soft tissue. So then I think that is likely to be fluid. And based on that shape, which has perfect, almost, as you mentioned, almost triangular with a very well-defined contour, I think that is very unlikely to be within the lung. Makes sense, lesions within the lung, if it's a MET, it can have well-defined contours, and those are focal lesions, but they are not going to be triangular like this. So what I suppose is happening here is that it's just a little accumulation of fluid in between two lung lobes. It looks not at the classic pleural fissure line, just because there is also pneumothorax. That will be my explanation. If I'm certain about it, I am pretty certain, but I could be wrong as usual. Anything else? So I think I will be happy with that list of findings. Now the challenge is, what happened? Now is a detective side of imaging. Well, how can we put all this together in a 1-year-old cat? I think we can explain dyspnea. Makes sense? So why is the cat dyspneic? I think we know there is pneumothorax, pleural effusion. I think that can easily justify the dyspnea. Now the detective work is, what is the underlying disease? What happened? How are we going to put all of these findings together in a 1-year-old cat that is dyspneic? So there I'm all ears. I want to know your hypothesis. And the way that I suppose we need to go is just bring an idea. Just say, what about this? And this is called like hypothesis testing. We bring a hypothesis and we say, well, if that is correct, then can we explain everything that we see based on this hypothesis? And then what it may happen is that we have one hypothesis, and then we decide, after going 2 steps forward, we decide, well, it doesn't really fit. So we need to trash this hypothesis and maybe have another hypothesis. So yeah, how can you, anyone willing to offer a hypothesis?
I think trauma is probably the one that everyone's thinking, but yeah. And
then, so continue. I like that one.
Oh, just like a hit by car or something like that. Cause multiple, I guess, problems.
So from all the features, can you explain them? So we have pneumothorax. Can you explain that by trauma?
Yeah, I guess if there was a rupture to one of the lobes or something like that.
Or airways.
Or airways or something. Yeah, then that would cause that. Those gas loops, if there is a hernia, then they could represent, intestinal contents or something that have gone through. The subcutaneous emphysema, I think, would fit with a traumatic incident as well.
Okay, hold on. So let me make sure I understand your points here. So the subcutaneous emphysema is because there's an interruption in the continuity of the skin.
Yeah.
Okay, so then there should be a laceration.
No, true, but well, I feel like if you get a really abrupt trauma, then if it's a really oh no, you've got a good point.
If the
No, well,
trachea in
I'm
We
trying to
couldn't
understand
find any wounds on the cat.
or what is the thinking? So the sub-Q, I like that sub-Q emphysema. You know, we always see it in trauma, or it's very commonly seen in trauma. But I want to understand the mechanism that you are using to explain that, which I'm not criticizing. You're saying, I'm saying, just to make sure I understand, you're saying, and we could have missed the laceration, but you're saying that the subcutaneous emphysema, in your mind, in your theory, is coming from the outside.
Yeah, I mean, I can't see anything. I mean, I guess I don't know if you would be able to identify emphysema coming from inside out on a radiograph. I just don't really know what to look for. So I guess, yeah, sort of my first instinct is to think that it's something that's coming from the outside, but perhaps that's wrong.
That's perfectly fine.
Yeah. Now, yeah.
If the integrity of the trachea is suspect, like there's a hole in it, it could cause the pneumomediastinum. It could cause the subcutaneous emphysema, but then there must be some trauma that's caused the subcutaneous emphysema. Sorry, the pneumomediastinum to rupture through into the main pleural space.
Okay, so beautiful statement. I want you to all listen to that theory, because that theory makes a lot of sense. Okay, so because there is gas in the mediastinum, then the possibility of having a ruptured trachea that is leaking into the mediastinum and explaining the pneumomediastinum. That pneumomediastinum is connected with the deep muscles of the neck and the subcutis. So if there is a rupture of the trachea, then we can explain the pneumomediastinum, we can explain the subcu emphysema coming from the inside. Makes sense? There we don't need skin laceration. And there, the next important thing is that there we could also explain the pneumothorax, because the pneumomediastinum can go to the pleural space. The parietal pleura that is forming that mediastinum can break, and then it's going to communicate the mediastinum with the pleural space. So that theory is perfect. Makes sense? So this could perfectly be a ruptured trachea. We don't see it here, and I've done that during the weekend. I said, you know, next time you do a follow-up in this cat, or if you want to do it now, take the neck, because we want to see the trachea. That's an important. I like this, and I hope everyone could follow the reasoning. Ruptured trachea, which happens in cats. Then there is leaking of gas in the mediastinum. That gas can go into the sub-Q, and it can also break into the pleural space, producing a pneumothorax. And if there was a trauma, then there could be also pleural effusion, like a hemothorax. So actually, that theory is a good one, because actually it can explain everything that we can see in this radiograph. We don't see the actual rupture of the trachea, and sometimes radiographically, we can actually see the separation of the trachea. And I'm happy to I have a couple of cases, so next rounds I'm happy to show you one. So that works perfectly fine. It doesn't necessarily have to be a complete separation of the trachea. It could be a little bit of a break of the trachea. So that's a beautiful explanation. Any other theory?
Well, when we didn't have a clue what was going on and thought it might have a bone opacity in its esophagus from the little thing, we were wondering whether it could have like an esophageal rupture or something. But I think like we ended up with, you know, the pneumothorax, the pleural effusion, and the white lungs, probably contusions, fits with trauma, but we couldn't put the pneumomediastinum and the subcut emphysema with them, so we couldn't get a.
So there, for a minute, you thought there could be a foreign body in the esophagus. We could explain everything
with one thing. Really.
That it was wrapped.
Yeah, but
the foreign body in the esophagus perforated the esophagus.
Yeah, and it was more like a you know, pyothorax with air. But yeah, we were clutching at straws at that point, I think.
I think that's a good thinking. My argument about that theory would be, and it's something that is probably I can't defend a lot, but is usually ruptures of the esophagus. They don't come with such a severe pneumomediastinum, severe enough to then rupture into the pleural space. But that is my experience. So, you know, and the reason for that is that usually there is not a lot of airflow in the esophagus. So the amount of pneumomediastinum is not that much. But it's a good thinking. Any other theory? Let me guide you in one. Let me present a problem. So, and this, what I'm trying to do is then probably finish up discussing what are the causes of pneumomediastinum. Could this be just a trauma case? And if it's just a trauma case, makes sense. So without the ruptured trachea, can we explain the pneumomediastinum? How can we end up with pneumomediastinum in a trauma case? Because one of the ideas was, well, let's break the trachea. And I like that. But what if it's not broken? And the pneumomediastinum, usually the pneumothorax. So if you have a reason for pneumothorax, usually the pneumothorax doesn't go into the pneumomediastinum because the pressure within the pleural sac would compress both parietal pleura layers, and it usually doesn't go in that direction, goes the other direction, goes from pneumomediastinum to pneumothorax, but not from pneumothorax to pneumomediastinum. So if I come back to that problem, the problem is, how can you explain, we explain pneumomediastinum in a trauma case without rupturing the trachea?
I guess, is it a young cat, Mariano?
Yes, 1 year.
Could it be that it's, you know, a conventional trauma case, but this cat also has something else congenital perhaps going on that is abnormal, or not really something you see? I don't know. I'm just sort of, I don't really know. I'm just sort of throwing it out there.
Okay, and so your idea is there might be something congenital
That's causing communication, yeah. But yeah, I'm just totally throwing, that's just a shot in the
dark.
dark.
That's perfect. So actually there is, and if we believe that these gas opacities are lung bullars, which I think they are, so then, you know, it could have happened that trauma resulting in rupture of one of these bullars, which I think is what happened. And then, however, at that point, I think can explain pneumothorax rather than pneumomediastinum.
Yeah, okay.
Okay, and here is where I wanted to have you, because this is, I kind of was leading you to this point, and is how should we think about pneumomediastinum? So the usual causes are rupture of something in the mediastinum, and the classic one is trachea or principal bronchi. And the classic examples are trauma or iatrogenic. You know, anesthesia, you inflated the balloon a bit too much, and now you broke the trachea, and now there is pneumomediastinum. Actually, if that happens, you will see like a bubble animal. Makes sense, because that communication between the mediastinum and the sub-Q is a very clear communication. So then you can even see, I remember having a case where they were doing a dental, and then the cut started to inflate. And basically they came rushing to imaging. We took a radiograph and it was like a ruptured trachea, iatrogenic. And then there was a lot of air accumulating in the sub-Q, and the cut was like twice the size because of the accumulation of the sub-Q gas. So that is one. And then the other one, which is a common one, is bite wound in the neck. So dog fight, big dog, small dog. Now there is a laceration of the skin in the neck. Now air is coming from the outside, and because there is no barrier, makes sense, nothing stopping that air from the deep muscles of the neck to the mediastinum. There is nothing anatomically separating those. Then air is going to go in the other direction. Makes sense, it's going to go now into the mediastinum. But in this case, that is not the case because there is no clear laceration of the neck. So this case, I think, goes into a third category, which is something that is in the book, And actually the book says that is the most likely cause, but it's hard to believe because the mechanism sounds very unfamiliar. If you go into the human literature, there are many situations where there is a pneumomediastinum, and they call it spontaneous pneumomediastinum, and it's usually secondary to anything that increases the pressure in the thoracic cavity. And the thing goes like this. If you increase the pressure within the lung, and that can be trauma, I think this is the case in this cat, there increased pressure within the alveolar space results in breaking the wall of the alveoli, and then air dissects all the way within the lung, following the arteries and the bronchi, and that ends up in the mediastinum. Okay, could you follow that idea? That is called Mackling effect, and is regarded as the most common cause of pneumomediastinum. Mackling effect, increased pressure within the lung, and that can be any situation like vomiting, coughing, trauma, you during anesthesia going too hard, increased pressure within the airway, goes outside into the periphery, into the alveolar space, they break the wall of the alveoli, that air goes dissecting on the other side of that airway and dissects and it goes back into the mediastinum. Okay? That is actually, it sounds very unfamiliar. We don't like to think about this because we see that it is very complicated, but it's regarded as the most common cause of pneumomediastinum. And it can happen secondary to anything that increases the pressure within the thorax. In this case, I'm sure the trauma, increased pressure resulted in both. Probably rupture of fibula, rupture of the lung, but it ruptured to the pleural space, but also increased pressure that forced that gas to go dissecting along the airway and along the arteries into the mediastinum. Okay? So for that, I wanted to show you something because to see if you believe me a bit more. So I have a beautiful case. I have two cases. I decided to show you this one. I have the one that I'm not going to show you is a case that I was doing research in Zurich, and then anesthetist with a sheep. And then the anesthetist was like very fan of no motion because we were studying the lung and we were studying like embolization of the lung. So we wanted to have motionless images. And I remember he went on the bag like this, so put a lot of pressure. And as I was seeing the image coming through, I could see the pneumomediastinum forming. And that was just him, too much pressure, and then all that air was dissecting and coming back into the mediastinum. And I have a beautiful CT. I'm happy to share that with you, and where you can see that air dissecting around the vessels. This is the second case, which is a recent case, and the dog was basically vomiting non-stop. And we were trying to search the reason for vomiting, and then we decided to do a CT. And look what we found. So hope you can see my images. So there is a lot of gas. That gas is in the retroperitoneal space. This gas is surrounding the aorta. Make sense? So this is a cross-sectional CT. So we are at the level of the caudal thorax. This is the aorta. This is lung. That's the separation between the pleural space and the mediastinum. And then there's gas dissecting all around, even in between the muscles of the mediastinum there. Okay? So now, if I need to make a diagnosis, I would say there is pneumothorax, there is pneumomediastinum, there is subcutaneous emphysema, there is retroperitoneal gas. Okay? Let's continue because the cool thing is gonna show up now. Now, look at this. This is a vessel. It's surrounded by gas. Look at this vessel. So let me make it larger. See that there is gas surrounding that vessel. There is gas surrounding that vessel. And if we continue that, do you see that gas? And gas surrounding this vessel. And gas surrounding that vessel. And that one. If you continue those, they go into the mediastinum, obviously. So that gas in the mediastinum is communicating with that space around those vessels. And this is the morphological correlation of the Mackling effect. Make sense? So that space that surrounds the airway and surrounds the vessel is communicated with the mediastinum. So either if you increase the pressure in the mediastinum, or if you increase the pressure in the airway and it breaks and then follows tracts along those pulmonary arteries, pulmonary veins, or airways, it's going to end up in the mediastinum. Make sense? So this is, hopefully this helps you buy this. It's not a theory, it's something that happens and we know happens, but it's kind of hard to anatomically grasp the idea. And it's basically the mediastinum here dissect or extends along that airway and along that bronchi. So if we increase the pressure within the lung, let's say trauma, the lung can break into a pleural space. So let's say if there is a bulla here, or even without a bulla, you increase the pressure within that lung, and now the lung breaks into a pleural space, that goes into a pneumothorax. If that break, instead of going into a pleural space, goes surrounding that airway, well, that is going to dissect all the way along and it's going to end up in pneumomediastinum. In this dog, we couldn't find a reason, and we think that is secondary to the increased pressure within the thorax because of the vomiting. And I've been looking at some human medicine literature, and basically it's described. They call it spontaneous pneumomediastinum. And the causes are vomiting, chronic cough, anything that increases the pressure within the thorax. It can break either way. It can go into spontaneous pneumothorax, but also could go into spontaneous pneumomediastinum. And a trauma case can end up in both. Spontaneous increased pressure, Mackling effect, gas dissecting along the airways into the mediastinum, or it could also go, or both, into a pleural space or both. So coming back to our case, I think the best way to put things together, I agree with the idea of having a trauma in this case. And then then probably one of these bulla rupture, not these ones, usually the ones that we don't see rupture, makes sense, because the bullas that we see are the ones that are gas filled. The ones, and therefore it's likely that they haven't ruptured. It's likely that there is an additional bulla that we don't see, that is the one that ruptured. That can explain the gas or the pneumothorax. And likely just the trauma on itself, with or without rupture of the trachea, can explain the pneumomediastinum through the Mackling effect.
Can I ask a quick question about that effect, Mariano?
Yes.
When they spoke about it, was it increased pressure but sustained? Like, was there a time frame that the pressure needed to be increased for, or is it can be just a bang and then that can push it back? Or
I don't remember reading about that.
Okay, cool.
But the examples that I could find in the literature are more probably like an acute high pressure rather than a sustained one. So again, the situation of coughing or vomiting or trauma, pretty much. Makes sense? So trauma, it's not that you have trauma for 5 minutes, you have boom, trauma, and that almost like breaks in multiple places, and then that air slowly goes and dissects and goes into the mediastinum. In people, they describe like classic feature, which is crepitus of the sub-Q on the neck. And that is just air dissecting through the mediastinum into the sub-Q. So it feels like gas that you can palpate on the sub-Q. So beautiful case. I just wanted to, I like these cases with pneumomediastinum and how to think about them. What are the possible causes of pneumomediastinum? I think they are very useful. And knowing a little bit and having in mind what are the things that can result in pneumomediastinum can help you in narrowing down the list or having a more thoughtful approach to a case. And I love those cases of pneumomediastinum where you can see the air dissecting along the airway and the vessels of the lung. It's a weird anatomy, makes sense? Because you think about the lung being the pleural sac, and that's perfectly fine. But through the hilus of the lung, let's say the hilus of the lung and extending along the airways and vessels, that is communicating with the mediastinum. Makes sense? So then an increased pressure within the lung, if it breaks the pleura, it goes into the pleural space. If it breaks the alveolar, the wall of the alveoli, then it can go into the mediastinum. Makes sense? So it's having that in mind, and remember that that is a possible mechanism. I find it useful. And again, in the book, it says it's the most common cause. And I love that CT because I think that proves it. Okay, in the last, any questions? There was a lot of talking on my side today. I try not to do that, but whatever.
I'm just wondering, have you ever had any cases referred to you that have been, you know, chronic cough or something like that, resulting in a in this condition, basically similar to people, or is it not something you've seen?
Well, let me show you the next case.
Okay.
So this is a case that I got yesterday. I was doing my teleradiology rotation shift, and I got this case. And it was just after Helen shared with me the other case. So I said, oh, interesting. Maybe we can put them together. So another beautiful example of, we can go fast with this one. So beautiful example of pneumomediastinum. And this, probably in this case, is a lot nicer in terms of that we have all the features. So now we see the outer contour of the trachea dorsally and ventrally. And now we can see these structures here, which are the brachiocephalic arch. This is likely the most ventral vessel in the mediastinum is going to be the cranial vena cava. So this is usually brachiocephalic arch, left subclavian. We usually can't see any of that. And again, because it's silhouetting with one another, this is the ventral contour of the longi colli muscle, which is always there, but we can never see it. Again, because there is soft tissue, soft tissue, soft tissue. Now, if we add gas, now we have more detail. We can see them all. That is the way that we diagnose pneumomediastinum. That gas in the mediastinum is dissecting along the facial planes of the neck, and now there is gas within the muscles of the neck. And if we go to the other projection, then there is also subcu emphysema. Sorry, there's subcu emphysema here. Okay, interestingly, in this case, there is no pneumothorax. Make sense? So the lung is extending all the way to the periphery. There is no separation of the lung from the wall. There is no silhouetting of the cardiac silhouette. The diaphragm is okay. So, and the history in this dog, let me bring, this, by the way, you have it in the forum, so you can open it. This is case 17. And this is a 10-year-old terrier mixed with labor breathing, panting, and chronic cough. So there we go. I'm sharing this, but I'm not sure I know exactly what happened. But one of the theories, if you look carefully, I think I could convince myself that there may be a bronchial pattern. So one of the theories that I offered was, oh, maybe chronic coughing, increased pressure, and now this spontaneous pneumomediastinum, and probably we should only deal with the coughing, and then that should resolve and no big deal. However, there is something else, and this is where I wanted to play with you a bit. Do you see something else? And some people hate this idea of the hypothesis testing, and they think that you should be, let's say, searching the image almost like a scanner, makes sense, trying to identify abnormalities. I love the hypothesis testing because it guides your attention. So if we go back to the possible causes of pneumomediastinum. Makes sense? Because that can organize our thinking. There is pneumomediastinum. Clearly, we need to be trying to figure out a cause for pneumomediastinum that is not pure pneumomediastinum. Makes sense? There is nothing else. There seems to be nothing else in this radiograph. So we go trauma again. It could be one trauma, spontaneous pneumomediastinum, increased pressure dissecting into mediastinum. Can you name other possible causes?
I'm
Again,
just wondering in this case if there's is some free gas in the peritoneal cavity, a little bit of it.
So one point there, so I'm not sure I see it, but if the way that this communicates anatomically is that if there is gas in the mediastinum, that communicates through the hiatus of the aorta into the retroperitoneum. So that goes one, that communicates, and then one can lead to the other one, but not to free gas in the abdomen. If there is free gas in the abdomen, then we need a complete separate explanation. Okay, so if we go in theory, so we need the Mackling effect, and it could be to anything that causes increased pressure within the thorax, including the coughing, but it could have been trauma. I don't see anything that makes me think about trauma. Makes sense? Any rib fracture, any fracture. So I don't see that, but that's a possibility. The other one was rupture of the trachea, and I don't see any foreign body. I think I can see the wall of the trachea, and I think it's okay. The other one is rupture of the esophagus. What do you think about that?
I think I'd like to see more fluid in the chest from a ruptured esophagus.
Okay, that's a good point. Yeah, but it's going to be in the mediastinum, so it's going to be tough to see. Because again, it's not going to accumulate. If you have a leaking esophagus, it's going to accumulate in the mediastinum, and it's going to end up in a mediastinitis. And that is tough to see radiographically because it's not going to accumulate around that lung in the pleural space. It's going to accumulate in the mediastinum, and that's tough to see, and it may take a little bit of time to form. Any other comments?
Here's a theory. If you have a blocked esophagus, so some sort of foreign body, and they're dry retching to try and bring it up, could that then cause the increased pressure and then the pneumomediastinum?
Yeah.
So I don't know. There's something potentially, but I can't zoom in enough to really in the left lateral. What are we thinking now?
So this is the outer contour of the wall of the esophagus.
Okay.
And we can usually don't see. And now because we have gas, we can see. There. Okay? So Calvina cava, that's the wall of the esophagus.
This is the vessel. Can I could you zoom back in, Mariano? If you could, I'm just having trouble figuring out what this is. It might be something really obvious, but what is that structure just there?
Need to annotate.
Oh, didn't I? I thought I did. Sorry, just there. That's a bit big. Oh, it didn't. Are you guys seeing that or no? Draw? Okay.
Computer says no.
Can you see that? No, it keeps disappearing. Oh, I don't know who. Well, it's just so one.
Click on draw and then click on the wavy line underneath it.
Draw and wavy line. So it keeps appearing for me and then disappearing, but basically it's just where the left atrium, where you'd measure the size of the left atrium. Just, yeah, that there. Could that be a lymph node or something?
I think it's the left atrium.
You think it's the left atrium? Okay, yeah, right.
Okay, so I'll show you. Oh,
there they are. Sorry.
Yeah, that's interesting. Let me show you what I was convincing myself about the bronchial disease and the coughing and the spontaneous, pneumomediastinum, but I wasn't that happy. And then at the end, I forced myself to go through things that are not calling my attention, because that's the thing that we miss things that call our attention. Like, I don't think anyone can miss the pneumomediastinum in this case, but you can miss small things that may be very relevant, but they're not really shining or calling your attention. And there is something that is very cool. Look at this. Do you see that? So I don't know if when I saw that, I said, well, that's a foreign body. That I have no question. My sense is square, is sharp, is a perfect size to go through the esophagus with difficulty, and it has sharp contours. So I don't know if this is the case, but another theory that we should be considering is that this foreign body was actually going through the esophagus with some degree of difficulty, and because it's so sharp, it lacerated, perforated the esophagus, and now it's in the stomach. And then, and there is no way I know that is the case, or this is an incidental finding. So it's a coincidental foreign body in the stomach, and then, or even more, maybe your theory about, could this all be because there is perforation of the esophagus, or it could be because it was retching and increasing the pressure in the thorax, or even trying to vomit on the same mechanism. But this is likely to be related. And I love the case because it's in the periphery and it's so easy to miss. And I remember I called the vet and I said, look, I have these theories. The theory, I may have forgotten something, but at the end of the day, my theories were bronchial pattern, coughing, increased pressure, Mackling effect, laceration of the esophagus, or something related with the esophagus and increased the pressure within the thorax, like gagging or vomiting, and that resulting in the pneumomediastinum, or trauma. Makes sense, like, it may have been that there is trauma, and same thing, Mackling effect, increased pressure in the mid. And when I was talking to him about this, he said, oh, actually, one of the things that the owner reported was like gagging. And they didn't put it in the history. It was more all about coughing. But then he said, no, what you're saying fits perfectly fine. There was gagging. So it's very likely that this is all related to the esophagus. So another case of pneumomediastinum, interesting, in one we had the multiple other findings, pleural fluid, pneumothorax, lung bullous, bulla. And then in this case, the thing that we share is the pneumomediastinum, but then there is no pneumothorax, and then there's that little possible story, with the foreign body in the stomach that is so easy to miss, and I think it has a relevance. And hopefully this helped us go through the thinking of pneumomediastinum. And next time you see a pneumomediastinum, you know how to pull from that finding and say, what are the possibilities? I need to think about all of them and then weight them based on the images. Okay. Any questions? Now we need to go and find another. They don't come very often, so make sure you don't forget all of this information, because pneumomediastinum is radiographically so easy to identify that it's good to know how to think about it. because if it's there, you can see it very easily, and then knowing how to react, is always pays back.
I find it really interesting that it doesn't need to be a ruptured something or a wound, because that would be what I would always be searching for. So it's good to know that it can just happen and there's not something you need to search for necessarily. Obviously,
Yes, I think you need to be thinking that there could be a rupture, but it doesn't necessarily mean that there has to be a rupture. And actually, if you go back to the book, it says that the most common cause is the non-rupture. Well, there is a rupture, but there's a rupture, is within the lung. There's nothing that you can go and fix. And that is regarded as the most common.
And that would kind of fit with that cat, because the ones I've seen with a ruptured trachea have had so much subcutaneous emphysema, and the cat just had a really tiny bit. You could easily miss it. So maybe that does fit more with the, is it Macklin? Is that how you say it? Macklin effect?
Macklin.
Macklin, okay.
Yes. I completely agree with you, Helen. I promise that I will try to find that ruptured trachea, and I agree with you. When there's a ruptured trachea, just because there's so much airflow and pressure gradients, then the amount of pneumomediastinum and the amount of subcutaneous emphysema is huge. Yeah, I completely agree with that point. Yeah. How is the cat doing?
Well, they ran out of money, so we basically couldn't do anything. But because it had presented 24 hours after the trauma and it was still alive, we kind of hoped that it would do well, and it actually did just do well, just with supportive care. So hopefully it's still doing well.
On ultrasound, it did have very wet lungs, so I think it had significant contusions as well, and that was probably causing most of its breathing issues.
Yeah.
And a bit of pleural effusion.
We need to thank you, Lucy and Helen, for providing these cool cases over the weekend.
Well, it's nice talking about them on Tuesday, not so nice seeing them on the weekend when we're like, what the hell is going on?
And this makes a lot of sense, like going through real cases and things that, and I suppose that for the person that had the case, and then, you try to understand and explain the images and everything, having the possibility of discussing them later on is a way to learn. Makes sense, because then you can go back and go back to your original thinking and see if you were right or wrong and how to modify that. So I think having rounds with real life cases sometimes it's boring, because sometimes there is not a lot, and I try to do the filtering. Makes sense. Things are cases are worth discussing, because there's something to, like, a take-home message or a learning point from those that are boring. But you've been bringing very interesting cases, so yeah, awesome.
Yeah, we've had a bit of a run of interesting ones.
Yeah. Okay, so I think we are done.
Thank you so much, Mariano. That was awesome.
Yeah, thank you.
All good. So we'll see
thank you, Mariano.
next Tuesday.
Cool. All right. Thanks, everyone.
Cool. Thank you.
Thanks,
See
Mariano.
you guys. Bye. Thank you.